Hello, I am Joe. I am a cardiologist. I would like to start my patient on a blood thinner to prevent a stroke as he has atrial fibrillation.
Hello. I am Napoleon. I am a pharmacoeconomist. What do you mean by the word patient?
I mean someone with atrial fibrillation, someone who I would like to help.
I do not understand. What do you mean, help?
To make someone's life better.
I do not understand. Why would you want to make someone's life better?
Okay, I need approval to start a novel oral anticoagulant and NOAC.
Now I see. You need to prescribe Warfarin.
But he does not want to take Warfarin.
Warfarin is cheap.
I feel that a NOAC is a better choice.
NOAC is dear. Too dear. He should get Warfarin.
But he is worried about stroke and wants a convenient medication.
Warfarin is cheap. He should take Warfarin.
But he takes several other medications. I am worried about interactions.
Warfarin is cheap. He should take Warfarin.
He works long hours and does not want the inconvenience of having to go for frequent INR tests.
Warfarin is cheap. He should take Warfarin.
He is worried about the risk of intracerebral hemorrhage. I feel a NOAC carries a lower risk of bleeding into the brain. Well?
Warfarin is cheap. He should take Warfarin.
If you had atrial fibrillation, what would you take?
That would depend.
That would depend on what?
That would depend on my renal function.
Well, suppose your renal function was normal, or you had a creatinine clearance above 15 milliliters per minute.
I might then take an NOAC.
Why can I therefore not give my patient a NOAC?
Warfarin is cheap. He should take Warfarin.
Well, what about the cost of the blood tests for monitoring in on Warfarin?
Our sensitivity analysis indicates that Warfarin is cheap. He should take Warfarin.
But what about the cost of travel to the Warfarin clinic and time lost from work?
Our Markov modeling could not allow for that.
How much does a stroke cost?
Well, that depends.
On what?
On how large the stroke is, the residual deficit, the length of hospitalization and the healthcare costs.
What if the patient dies of stroke?
Oh, that is extremely cost-effective. Dying suddenly has a quality-adjusted life-year value of $50.
Will you approve my application for the 65-year-old man with atrial fibrillation, diabetes, hypertension, prior bypass surgery and a left ventricular ejection fraction of 30%? He has normal renal function.
He should take Warfarin. Warfarin is cheap. I love Warfarin, I do.
Well, why don't you stick your Warfarin?
I don't understand. Warfarin is not adherent. It comes in 1,3 and 5 milligrams tablets. How would I stick Warfarin?
That's my point. How could anyone stick Warfarin?